We are live. Good evening, everyone. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 45th episode of Optometry series. I'm very happy to welcome my team members, Ms. Anshika ma'am and Ms. Meenakshi. Hi, both of you. Yes, thank you so much for joining. And Anshi ma'am, so we are doing the Back to Basics series, and today is the part 3 of Back to Basics series. So, what topics we're going to discuss today, and who's today's moderator, ma'am?
Hi, Gomati. Hi, Meenakshi. Hi, Hashmath. Very much welcome to our optometry series. So, as you all know, we are going along with our back to basic series. And this today we are going to have about IPD, confrontation, and stereopsis. And I'm very happy that we have Hashmath with us, who is a very good faculty as well as a clinician. So I think when we go into back to basics, we need someone who can, pinpoint just a very small detail so that we do the procedures correctly. So I think Hashmat would have been the best one to help us out today. So thank you for joining us, Hashmat, and over to the MC to introduce Hashmat.
Good evening, everyone. I am Vignesh, a second year Bachelor of Optometry student and a multimedia member at Dr. Agarwal Institute of Optometry. It's given me a great pleasure to welcome today's moderator, Ms. Ashmet Sultana. Ma'am is an optometrist and academician. She completed undergraduate studies at Elite School of Optometry, Chennai, and her postgraduate at Chitkara University, Punjab. Ms. Ashmet Sultana, ma'am, brings with her over 10 years of clinical and academical experience in optometry. She served as a faculty member at our college and later worked as an assistant professor at Vasant Institute of Ophthalmology and Research, Chennai, where she taught both undergraduate and postgraduate studies and guide several projects in optometry. She had also received specialized training in vision therapy from Shankara College of Optometry, Bengaluru, and currently served as a General Secretary of Elite School of Optometry, Alumnium Association. She area of interest include vision therapy, low vision, and occupational optometry. We are truly honored to have you as a moderator today. Ma'am, thank you for so much. Thank you so much for joining us.
Thank you, Vignesh. Thank you for the warm welcome. You
Thank you,
elaborated
ma'am.
so much about me. Thank you, Anshika, for bringing me here and warm welcome also.
Now we move on to the presentation. I would like to invite Ms. Aswitha, second year masters in optometry student at Dr. Agarwal Institute of Optometry to begin our presentation. Ms. Aswitha, please take over.
Thanks, Vignesh. Good afternoon to everyone. Today we are going to see about, in this video, we are going to see about interpupillary distance, confrontation and stereopsis. First, we are going to see about interpupillary distance. Interpupillary distance refers to the distance between the center of the eyes measured in millimeter. There are three techniques. First technique, manual measurement. Using a millimeter ruler placed at the nasal bridge, measuring the distance between pupil centers. Second, we are going to measure with digital method. Automated device or apps that use cameras and software to calculate interpupillary distance. Third method we are using for measurement, pupillometer. A specified device designed for precise IPD measurement in both distance and near vision. In this first picture, we are going to see about In this first picture, we are going to measure the pupil centers in millimeter. In the second picture, we are going to measure right eye lateral limbus to left eye medial limbus. Procedure for binocular PD. Purpose to determine the distance in millimeter between the entrance pupil of the two eyes for a given viewing distance. Equipment we are needed. Ruler marked in millimeter. Setup. The examiner sits directly in front of the patient at eye level. The examiner face should be positioned at the patient's near working distance, usually at 40 centimeter. Procedure for near IPD, target nose bridge or aligning examiner's right eye to patient's nose bridge. Shine a light, align the 0 point of the ruler on the patient's right eye at corneal reflex. Measure till the corneal reflex of left eye. Document the reading in millimeter. By procedure for distance PD, Instruct the patient to look at the open left eye of examiner, close the right eye, align the 0 point of the ruler on a nasal pupillary edge of the patient's right eye. By closing the left eye, instruct the patient to look at the just to open the right eye, measure to the corresponding temporal bridge pupillary edge on the patient's left eye as described above. Recheck the entire procedure. This picture shows we have for distance PD, we have to ask the patient to look at our open eyes, and the dotted line shows the limbus to limbus measurement. For IPD measurements, we are taking in a 3 method. First one, corneal reflex to corneal reflex measurement. Second, pupillary edge to pupillary edge measurement. Third one is limbus to limbus measurement. It is a demo video for IPD measurements. For documentation, we have to write separately for distance and near, OD, OS and OU. In documentation, we have to document as M. For confrontation test, the confrontation visual field test is a simple non-invasive procedure used to assess the peripheral vision of a patient. It helps detect visual field defects such as scotoma or area of vision loss, which may result from conditions like glaucoma, optic nerve disorder, or neurological disease affecting the visual pathway. Procedures purpose to detect the peripheral vision loss or abnormalities in the visual field. To screen for conditions affecting the optic nerve, retina, or visual pathway, such as glaucoma, retinal disease, neurological disorder, example stroke and tumors. Room setup: ensure the room is well lit with no distractions. The examiner and the patient should sit at eye level in the comfortable position. Testing distance at 1 meter. Both the examiner and the patient should cover one eye. Instruct the patient to look at your open left eye throughout the procedure for checking its right eye. Ask the patient to count the number of fingers shown. Avoid holding up 3 fingers because the stimulus is too easily confused with 2 or 4 fingers. Like this only we are going to measure confrontation test. Repeat the above steps in the appropriate 8 location in the field on each side of the 4 visual field meridians. Once the visual field of the right eye is marked, ask the patient to occlude the right eye and repeat the steps for the left eye. Throughout the test, monitor the patient's fixation and remind them to maintain the fixation on the examiner's open eye. This is performed in static and dynamic method. This demo video is for static method. This test is for dynamic testing. Record the results or each eye separately. Use finger counting field to identify the procedure. If the field is normal, write full. If the field is abnormal, write restricted followed by the location of the restriction. Third, we are going to see about stereopsis. Stereopsis is the perception of depth and three-dimensional structure that result from the brain's ability to process the slightly different view from each eye. When object in front and behind of the point of fixation stimulate horizontally disparate retinal elements simultaneously. Fusion of such disparate image result in a single visual impression. Reside in depth. Measure in seconds of arc. 1 degree equal to 16 minutes of arc. 1 minute equal to 16 seconds of arc. Normal stereo acuity is greater than 60 seconds of arc. Methods for measuring. There are 5 methods: Titmus flight test, TNO, Lank, Frisby test, random dot stereo acuity test. First, we are going to see about Titmus fly test. It consists of two plates in the form of a book. Polarized glasses should be used to test this plate. Test setup. Right side fly to assess gross stereopsis. Left side circles and animals to text finger stereopsis. Testing distance at 40 centimeter. Fly test measure gross stereopsis 3000 seconds of arc. This level of stereopsis is typically measured in young children. Expected response: if the stereopsis is present, the fly will appear in three-dimensional, demonstrating depth perception. If there is no stereopsis, the fly will appear flat and two-dimensional. Animal test. Purpose: to measure finger degree of disparity and depth perception. Setup: three rows of animals, each with varying level of disparity. Degree of disparity: normal stereopsis ranges from 400 to 100 seconds of arc. Then circle test. Setup: 9 circles, each consisting of 4 smaller circles. Disparity: one of the 4 circles in each set has a disparity. Normal stereopsis: the circle with the disparity will appear to be forward in three-dimensional space. Degree of stereopsis: normal stereopsis is between 800 to 40 seconds of arc. TNO stereopsis test. Purpose: to assess global stereopsis. Equipment: 7 plates with random dot patterns. Red-green spectacle for viewing. Distance at 40 centimeter. Test setup. The plates contain various shapes such as square, circle, cross, inverted triangle, and diamond. Test sequence. The first 3 plates are used to establish the presence of stereoscopic vision. The remaining plates are used to quantify the degree of stereopsis. Degree of disparity ranges from 480 to 15 seconds of arc. Lang test. Purpose: to screen for global stereopsis in children without the need for special spectacles. Test setup. The test uses random dot pattern and cylindrically grating to assess depth perception. Degree of disparity. The test evaluates stereopsis with disparities ranging from 1200 to 600 seconds of arc. Specified shapes used for testing include: for star, disparity of 600 seconds of arc. For cat, disparity of 1200 seconds of arc. For car, disparity of 550 seconds of arc. Frisby stereo test. Purpose: a real stereopsis test used to assess depth perception based on the physical thickness of the plates rather than relying on special glasses or red-green filters. Test setup. The test uses 3 transparent plates of varying thickness at 6 mm, 3 mm, and 1.5 mm. The plates contain 4 squares with printed random shapes, one of which has a hidden circle to assess stereopsis. Degree of disparity. The degree of disparity ranges from 600 to 15 seconds of arc. No special glasses are required, as the disparity is created by the thickness of the plates, suitable for any age group, including preschoolers, making it versatile for use in children and adults. Random dot e-stereoacuity test. Similar to Dittmer's fly test, fly is replaced by 4 squares in 2 segments and 3 of which contains geometric shape. Disparity ranges from 500 to 250 arc seconds. Other plates contains animals in 3 rows and circles of 10 segments. Animal test. 3 rows of animal, each with varying level of disparity. Degree of disparity. Normal stereopsis ranges from 400 to 100 seconds of arc. Circle test. Setup: 10 circles, each consisting of 3 smaller circles. Disparity: one of the 3 circles in each set has a disparity. Degree of stereopsis. Normal stereopsis is between 400 to 20 seconds of arc. Before begin the test, check right and left eye responses. While occluding the right eye, right and vertical line should be seen. While occluding the left eye, left and horizontal line should be seen. Equipment we needed: polarized glasses or red-green glasses depending on the test used. Stereo test booklet or test cards. Example: random dot test, Titmus, Bernal, TNO test, random dot E, and pass test. Random dot tests are preferred because they have few monocular cues. There are stereo tests available that do not need polarized or red-green glasses. Example, the Fresby stereo test, Land stereo test. These are used chiefly in examining young children who will not tolerate wearing the test glasses. The patient wear polarized glass or red-green glass over his near correction. The patient holds the stereo target at 40 centimeter. Instruct the patient to tell what she sees. Starting from the gross to finer acuity, continue testing until the patient gives an incorrect answer and recheck that twice. While recording, we have to record stereo at near and we have to record the name of the test used. If we are doing with correction and without correction, we have to record that. Record the stereopsis in seconds of arc, the last correct response given by the patients. If the patient does not perceive any of the stereo target, record no stereo, record the name of the test used. Expected findings, stereo at near 20 seconds of arc. Other screening, random.e and pass test. Random.e test, purpose to screen or the presence of stereopsis in young children. Equipment we needed, polarized glasses, random.e cards, stereo E, blank card and model E training card. Setup, the patient wears polarized glasses over his near correction, hold the model E card at the distance of 50 centimeter, point to the E and say to the patient, see the E or see the letter. Pick up the blank card and shuffle it and the model E behind your back. Show the blank card and the model E to the patient and ask the patient to point to the card with the E on it. Repeat step 3 until the patient correctly identifies the model E 3 out of 4 times. Randomly vary the position of the model E during each presentation, up, down, right or left. If the patient is unable to identify the model E, stop the test and record that the patient is unable to do the test. Then replace the model E with the stereo E card. Shuffle the 2 cards, blank card and the stereo E card behind your back. Place the 2 cards side by side or one above the other and ask the patient to identify the card with the E on it. Be careful to hold the cards with the upper edge tilted slightly toward the examiner so that light from above falls on the card without any glare. Repeat steps 5 at 50 centimeter 5 times. If the patient is unable to identify the stereo E4 4 out of 5 times, stop the test and record unable to do random.e at 50 centimeter. If the patient is correctly chooses the stereo U 4 out of 5 times at 50 centimeter, repeat the test at 150 centimeter 5 times. Expected findings, the patient should be able to identify the stereo E 4 out of 5 times at 150 centimeter. Pass test. The preschool assessment of stereopsis with a smile test is available in 3 versions. Pass 1, blank card, demonstration card and stereo smile card with the disparity of 720 seconds of arc. Pass 2, blank card, demonstration card and stereo smile cards with the disparity of 480 and 240 seconds of arc. Pass 3, blank card, demonstration card and stereo smile card with the disparity of 480, 240, 120 and 60 seconds of arc. The stereo smile test 1 is done in the same manner as the random.e, but testing is done at 40 centimeter. Pass 1 is used or screening. Pass 2 and pass 3 are used to measure the patient's level of stereopsis. Thank you.
Thank you so much, Aswitha. It was a very elaborative presentation. Now I request the moderator to add your inputs, ma'am.
Okay. Firstly, am I audible, Meenakshi?
Yeah, ma'am.
Okay. Firstly, I would like to tell Aswitha, it was a well done job, Aswitha. Your presentation was elaborate, informative. Yes, this is a small procedures that we do in our clinical OPD, which is very important in many of the clinical situation diagnosis. But most of the time, we miss in the procedure way method, or we miss doing it. Okay, so thank you, Anshika, for bringing these topics back into the your optometry series also. And before I add on my points, I would like to thank team of Dr. Agarwal Institute for giving me opportunity to moderate the session. And you are doing well with this series. It is actually very helpful for many of the people. and you're bringing in people from different streams to moderate your series. I would like to again thank Anshika for inviting me and Gomati for arranging me technically to the session. I would also like to, I'm actually very happy to deliver my talk with the Agarwal Institute, because after a long time I'm back with meeting students of Agarwal. I was there with Agarwal, and for quite some time it's again back. I would like to also thank Fauzia ma'am, who actually gave me an opportunity into teaching, where I first started my teaching journey in optometry from Sri Prakash Institute of Optometry, which later turned to Dr. Agarwal's Institute. Okay, I will share my. Okay, is my screen visible now?
Yes, ma'am.
Okay. So Aswitha actually told all the different methods of testing interpupillary distance. So like before, what I usually tell students or the people in optometry is, before like knowing what you are doing, you should know why you are doing it. So I will be adding few points about why we have to do all these procedures in our clinical practice. So yes, we have to measure interpupillary distance. We have IPD ruler. Using IPD ruler, we can test IPD. Then we have pupillometer. So in pupillometer also we have options where we can test for distance and near. Usually distance, where we have to set it at infinity, and near we usually have two distance options available, 40 centimeter and 30 or 33, depending upon the devices. Or we can also use auto refractors, which gives us, whenever we are measuring the refractive error, we also get the PD measurements. We can take that also. Now usually there are errors that happens when we do manually using interpupillary distance IPD ruler. Okay, so I felt this optical vernier, which is available in Amazon and some other places also, no, which overcomes that parallax errors which we get with the IPD ruler. And IPD measurement, whenever we do, no, it's better we do monocularly. And if when we want binocularly, we can add up, or we always get that add up. So why monocularly, I will say, is IPD varies with different ethnicity, with different genders, and with age. And also when there is going to be any asymmetry in the face, the IPD varies from right to the left. So it depends, we should measure, it's unique for each and everyone, so we should measure monocular. And for everyone, we cannot like tell that average is there, we will take that average. So when we do that, we end up with so many problems, because IPD, when we are not doing it with customized for the each patient, they will have difficulty in their visual functions. Like for example, they will have difficulty with stereopsis, convergence level, accommodations, even the vision amount, no, it changes. So as I was already telling, we need to know whatever the clinical procedure is, what are we doing. So like we are going to talk about the three procedures we know. How are we going to do that was elaborately given by the Aswitha. I will tell why we need to know IPD measurement for each person. Is it is very important when we are trying to dispense the glasses. So when we are like any type of glasses, it be a high refractive error or low refractive, high refractive index glasses, or presbyopic lenses, bifocal lenses, it is important to customize the glasses with the patient's IPD level. So we need to customize it with their IPD. When we don't do that, is we do with an incorrect value, or we do with an average value, what happens is it can lead to intolerance of the patients. So like once they will buy the glasses, they will start wearing it, they will have difficulties, they will face astronopic symptoms, they will find some prismatic effects because of the decentrations of the pupillary distance, they can have even diplopia because of that. And sometimes when we don't give the IPD properly in the progressive lenses, it can also limit the intermediate and near field of view. Okay, so where else for what purpose else we measure IPD is when we are calculating the AC by area ratio. So when we are calculating AC by area ratio, one important factor is IPD. We have two methods. One of the method requires IPD measurements. So IPD, how it varies is higher IPD will give you a higher AC by ratio. So which indirectly tells you that there is a increased demand for near. So that is what will be told in this, and vice versa it goes. Sometimes IPD helps in diagnosing some of the clinical conditions, like for example hypertelorism. Hypertelorism is nothing but where the distance between our both eyes or the pupil centers are going to be high. They are going to have the broader face and things in this. Some of the syndromes also will have higher IPDs, so we need to measure, document their values. What happens when we are using, we have different methods we have seen until now. When we are using manual methods, there is a poor repeatability which is found with the manual methods. Like for example IPT ruler. So I will usually suggest, if possible, when dispensing glasses, when you need to measure IPD, use your pupillar meter, or try to do your manual method with least errors. Where these errors can happen is, first main error that is possible is the parallax error. So I see, like in my teaching clinical examinations, everywhere where I see is people or the students do IPD measurements with a parallax error. That is, the eye level is not maintained. So eye level is not maintained, and since the patient and the examiner should be in an eye level, so that is not maintained, means it will give you a parallax error. So that error is actually sufficient enough to cause intolerance in the patient. Okay, so sometimes what happens is they don't hold the ruler properly. They tilt it or they keep it one sided. They don't fix that zero on the edge of the tip of the nose, so that time it can cause errors. Sometimes what happens is, first we measure left eye and then we measure right eye. Usually the procedure has to be done for the right eye first and the left eye next. And when we do some way like this and we document it, we tend to have some errors. Errors are normal, but when we do like these errors, it will be difficult, lead to problems. So yes, in nowadays we have IPD measurements like using digital devices which can be done, she told. I will just like to name few of the applications which are available nowadays. Some are of free of cost and some are paid, and some are for Android users and some are for iPhone and iPad applications. Like we have pupil distance meter app which can be used for Android phones. It can be downloaded in your Android software and then can be used. We have Opti app which is designed by then SL or Luxottica and being used. So usually what they do is they give us few instructions, that is to place the camera at a distance, and they take the picture and they try to calculate their IPD based upon the pupil reflex. They will calculate and they give us. Like, I wanted to bring this because sometimes when we have to dispense glasses and when the patient is far away and we are not able to do, we instead of when we have to do something to find their IPDs, we can use sometimes this apps. But yes, the authenticity, that is how the values are accurate with this, are still in the phase of knowing only. We still don't know, but still availability wise we have these apps too now. Okay, so yes, documentation is very important. So I will like to tell, like, whenever you're documenting IPD, it's important to tell the method that we are using. So you can like say is interpupillary distance measured using pupillometer, using IPD scale, using the app like pupil distance meter app, whatever you are using, and then you can document the values. Usually don't forget to write the units. Units are very important everywhere. So right eye and left eye for the distance, and near, when you, at distance, like for example pupillometer, you're measuring at 33 centimeter distance, then you have to tell. Or usually when you're using an IPD ruler, we don't mention this distance because we give a fixation is our center of the eyes, here we give. Okay, so yes, stereopsis. Why do we measure? Where, for who all we should measure stereopsis? We actually, because of the availability, I will say, because of the information that we don't know whether we need to do the stereopsis test for these people or not, we actually tend to miss doing stereopsis for many of the patients which come into our clinic. So I will like to tell that it is like, it will be better if we are trying to document stereopsis values for who all we suspect any binocular vision problems. So in cases of amblyopias, like in cases of children who come with difficulty of learning difficulties, reading difficulties, so when they come, no, it's better we document stereopsis, not only for children and young adults, even in elder patients who have been like who have neurological disorders or traumatic brain injury case. If you get to see, it's better to document stereopsis values, because researchers have showed that all these people have reduced stereopsis. Stereopsis is one factor which has been affected. So clinical importance of this, if you say, when we try to do stereopsis, we'll be able to detect whether they will have problems in stereopsis or any other eye problems, and we will start to manage that. Even when we start to manage that with management, whether the stereopsis increase, so that is one of the positive response that we will get, positive feedback response that we will get from whether the treatment is going on. Like for example, we plan for vision therapy for amblyopia. When we are trying to do vision therapy for amblyopia, when their suppression reduces, you see increased stereopsis level. Like for example, when you first check them before any treatment, 400 arc seconds was there. So once you have started your sessions in vision therapy and you have worked on anti-suppression exercises and everything, later your stereopsis gets improved. I will not say like it will come to normal, but you see a increase in stereopsis level, so that will give you a positive feedback, so you can monitor the progression of the disease or whatever management you are doing when we regularly do stereopsis in these cases. Okay, so I would like to say like you can also perform stereopsis for patients who come with these complaints for you. Okay, so what happens when stereopsis is poor? They have difficulty with double vision, they will have complaints of double vision. So with double vision, they can come with their daily task which gets affected is their reading difficulty. So reading could be any kind of reading. It could be digital reading, like from your any documents, or it can be books, anything it could be. It could lead to poor depth perception. So depth perception, when it is poor, what happens is they will have difficulty in sports activities. Most of the sports activities require good depth perception, like for example cricket, where the ball comes in, when you have to catch the ball. Okay, you need to identify the depth, how speed the ball is coming, where it is coming. It is important to to see. Now chess also requires good depth perception when there is a movement which is happening. Most of the games, indoor and outdoor games, require good depth perception. Driving also gets affected when there is a poor stereopsis. The other symptoms that you will get to see in patients with poor stereopsis is blurred vision. They can complain. Night vision gets affected. They may complain of crossed strabismus, that is intermittent strabismus. You can see poor hand-eye coordination. Yes, it can also lead to vertigo. Okay, so sometimes what happens, poor vision can also affect people doing their work tasks. Like for example, any occupation which requires near distance, like for example computer users, goldsmith, all those people will have difficulty doing it on long run. Okay, so like when you measure the stereopsis and then you get to see a normal stereopsis, that tells you an information about a normal binocular function in the person. So yes, all these things was elaborately told by Aswitha. One thing I would like to add is, whenever you're documenting stereopsis, you need to document which chart you are using and arc seconds. So like we say 15 to 30 arc seconds is normal stereopsis values. So we do expect within this ranges. Okay, these all stereopsis, your rand dot fly, all requires a polaroid glasses to see and respond, whereas your frisbee and lang doesn't require any of the external glasses, nor polaroid nor anaglyphs. Your TNO requires a anaglyphs to perform. Okay, to talk about confrontation. Confrontation is one of my favorite tests to say. Okay, so I it's actually a screening test which will not give you any perfect diagnosis, or based on this results we cannot diagnose any conditions, but still you can identify or you can screen for visual field defects with your confrontation. This test is a subjective test where patient has to say, uh, here the fixation is very important. The patient has to maintain the fixation throughout the test. Usually what we do is we ask the patient to close, like when we are performing the right eye, we ask the patient to close the left eye and they have to look into the straight eye. We will also close the left eye and we will keep the eye open. The eye, if the right eye of the patient is open, the left eye of ours is open and it will be straight. They have to maintain that. We do this test monocularly to see the visual field angle. Okay, so yes, there are two methods that you can do. One is, as she also told, dynamic we have static. So dynamic or kinetic. Firstly, I will what I will recommend is, we usually perform a dynamic procedure or a kinetic procedure. So what we do is we bring the target from the non-seen area to the seen area. So we will usually we can use targets like a pencil with a cap, or a thin stick with a bright colored cap or something like that we can use. Or if you don't have anything like that, you can use your fingers also. Bringing it from your non-seen area to the seen area is very important. So what we do is we try to bring the finger from a non-seen area to the seen area. So once we will instruct the patient to tell us once they start seeing the finger. So once they start seeing the finger, then we perform the static thing. So when we are doing like this, we will know the isopter. We can draw an isopter, that is the extent of the visual field area that they can see from the point of fixation. So with this, we will come to know whether there is any restriction in the field, or if they have any field effects, we can come to know with this. Okay, so then only kinetic finding the isopter is not enough. So we will see whether they are able to count the fingers at the point where they say they can see. So we will show the target. So once they say yes, they are able to see, we will document it like for, and we will be performing at 8 positions. So that is superior, inferior, nasal, temporal, superior nasal, superior temporal, inferior nasal, inferior temporal. Expecting it to be 45 degrees away, all the things are. Okay, so and one more thing is, we usually compare it with us. We as an examiner, optometrist as an examiner for this procedure, we expect ourselves to be normal. We compare our visual acuity, sorry, we compare our visual field with the subject's visual field area. Okay, so when we bring it from very far area, when we are not able to see, yes, obviously they will also not be able to see. So then what we do is we slowly bring, when we are able to try see, they should also be able to see. So once they say yes, they are able to see, then it's normal. And once we start seeing it, but we have to bring it very closer to their face, where they will then only say that I am able to see. That means there is some restriction in their visual field that you can see. Okay, projecting of the target, okay, that is also very important. So we usually use 1, 2 and 5 as the target in the static confrontation test that we do. And one more thing I will say is, the distance between the examiner and the subject or the patient is usually 50 to 70 centimeters we can maintain, and the targets which you show should be in between both, not very closer to the patient's or the subject's face, or not very close like this you show. That is incorrect. Okay, so documentation of this, we do it in two ways. The documentation which is showing on the right side, which says CF, 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 it is dividing the visual field area into the 4 quadrants, and it has been shown. Like for example, first picture where it is saying CF, CF in both right eye and in the left eye, that means they are able to count fingers in all the things. Whereas in the B picture, if you see, they are not able to count it. They have only CF, CF in the center. In the peripheral, they don't have. That means they have a bitemporal hemianopia. They are not able to see. So that is shaded in the gray color. Whereas in the C picture, if you see, they have an homonymous hemianopia. That is, they are not able to see. One eye's nasal side and one eye temporal side is not seen. Okay, this is one way. This method is followed in many places. Most commonly what we follow is this method, that is which is there in the left side, where I told you we will be testing in the 8 directions, right? If you can see this angles which I have shown here, that is 0, 45, 90, 135, 180, 225, 270. We draw it like an asterisk mark, okay, for representing right eye and representing left eye, and we use the tick mark or a cross mark to show the whether if the patient has responded rightly, we show it with a tick, and when the patient has not responded, that is they are not able to see, we do it a cross. Okay, and it is very important to give comments here, in because this is a subjective test and a screening test. We need to give comments here. Like for example, if you feel there is a restriction in the field, either superiorly or inferiorly, you are supposed to mention it there. So that becomes a indication for us to perform the further test, like going for a automated perimetry or other test. Okay, thank you.
Thank you so much, ma'am. You gave us the insights about what is the significance of measuring these procedures and when to be clarified or when to do this procedure at very cautional level. IPD, as you said, we neglect IPD so easily because it is not a routine procedure, but it plays a vital role in dispensing aspects. And as you said, stereopsis again is a prerequisite for all the eye and coordinations. So from the student's perspective, I do have certain questions, ma'am. I'll read out for you.
Yep.
First question is, what is the target for giving IPD? Near target and the distance target.
Okay, so it depends upon the method you're doing. When you're doing a manual IPD using an IPD ruler, what we usually do is when we are testing for the distance, we give the open eye. That is, when we are testing for the patient's right eye, we keep our opposite eye open and we ask them to see. Whereas same for the other eye also, when we are measuring near with a manual procedure, we give our center nose bridge, we give tip of a nose bridge, we give.
Thank you so much, ma'am. The
Whereas
next question is,
I'll just add, in the digital procedures, it actually has the target. Like for example, when you see pupillometer, it has a light which you have to see, and we coincide the Myers there and we take it. We have the manual options of changing it to distance, infinity, and near 33 centimeters somewhere.
thank you so much, ma'am. The next question is, which stereo acuity test is better and reliable?
Okay, so this is actually a tricky question to answer, because there are so many researches which are being done, and still, yes, when you perform stereopsis where we look into the depth perception, there are stereo acuity charts which also has monocular cues which will be seen, and either the child or the patient is able to answer. But most of these tests are also like, it includes your monocular cues. I will say random test you can use, where it tries to avoid or eliminate most of your monocular cues, and it tests mainly your binocular function, I will say. But still, yes, availability of what test you have in your clinic, you have to use that only. So you at least get some value of measurement there.
Thank you so much, ma'am. The next question is, how do we measure IPD for nystagmus?
Nystagmus. Okay, it's actually a challenging one to perform in patients with nystagmus. So accurate measurement becomes very difficult there. But what we usually do is when we ask the patient with nystagmus to close one eye and when we measure the IPD, it becomes difficult. So we do an approximate method of we can give them high plus lenses in front of the other eye which we are not measuring, where the nystagmus level will not increase. Okay, and we can give that and we can try to do some value for the other eye. You can also perform pupillometer to get an approximate value. Exact value, it's actually challenging.
Thank you so much, ma'am. Then, from the practitioner side, what common mistakes do you find when the students are doing these procedures?
I have actually kept that in mind and only made my procedures saying students do this parallax errors which are common, which has to be avoided to get an accurate values. Yes, how much ever we say students, they do some mistakes, it's out of the exam fear or things, but yes, with practice they do develop doing it right. And once when they know why they are doing it and what they are doing it to find out what purpose and why we are going to do on that person, then they will do it rightly. We need to teach them that also. I
Very
hope
true,
I have
ma'am.
answered this.
Sorry, ma'am?
I hope I have answered for this question.
Yes, ma'am. That's all with the Q&A session, ma'am. Over to Gomati.
Thank you so much, Ashmath ma'am, for the detailed explanation. Actually, it was great having you here, ma'am. Thank you so much, ma'am.
Thank you, Gomati.
Yes. Yes. Thank you, Meenakshi, for conducting the Q&A session. I'd like to thank Anshika ma'am also for joining with us today. And Ashmath ma'am, we would like to host you on another wonderful platform, ma'am. Thank
Oh,
you so much for joining.
thank you. So
Yes.
we'll end the session here.
Yes, ma'am. We'll end the session here. I just have an announcement to make, ma'am, for the general audience, and then we'll end the session.
Okay.
So, Aswitha, that was a wonderful presentation, Aswitha. So, dear audiences, thank you all so much for your continuous support towards Optometry series. Announcement for this particular week is at BIO, we are gearing up for the first and the wonderful section in 2025, which is our scholarship examination. I'd like to give a thumbs up and all the very best for all the students who's going to take up the scholarship examination. I'd like to take this opportunity to thank Divya Pratipha ma'am for coming up with this great initiative year after year. So thank you so much, Divya Pratipha ma'am. And students, those who are taking the scholarship examination, keep it in mind that it is going to be completely a merit-based one. So whoever is going to top in your batch will be getting 25,000 rupees of waive off from your fees. So all the very best students do well. And thank you so much, Ashmath ma'am. With this, we'll end up the session.
Thank you. Thank you all. Bye.
Thank you all. So audiences, if you like this video, please share it with your friends. We'll meet you in the next